Welcome to North Mississippi Medical Center Women's Hospital. We are located in Tupelo, Mississippi. This presentation is about life at our hospital after the COVID hit. Your presenters will be the educators here at the hospital. From left to right is Charmaine Douglas. She's the educator for surgery. Myself, Renee Nichols. I'm in the NICU. Casey Peoples is in labor and delivery and the OB/ED. Kayla Reich in Mother Baby and the Resource Pool. We are located in Tupelo, Mississippi. We are part of the North Mississippi Medical Center Health System, which is a 640-bed regional referral center. But our hospital is freestanding from the main unit. It was opened in 1986. We have 15-bed labor and delivery rooms, an 8-bed OB emergency department, a 30-bed NICU level 3 unit, and an OB/GYN surgical service, and 36-bed mother-baby unit offering couplet care. As far as visitation goes, we're allowed to have for a C-section mother. One person is allowed in the OR for spinal or epidural patients. No family is allowed in the waiting room. In labor and delivery and mother-baby, first was one support person that had to remain the same throughout the entire hospital stay, and now it's one person every 24 hours. In the NICU, we allow the mother and one support person for the entire hospital stay, and whether the support person is the father or someone else, that person cannot change. And unfortunately, we don't allow, before we allowed grandparents, and that's not allowed anymore, and it's just the mother and the support person. As far as short stay surgery and GYN, they have one visitor present just to drive them home. And something that we are fortunate in is that our mother-baby unit is on the first level. So we put the patient's room number on the windows so that the family can come to the outside of the window and they can see baby, they can see mama, and still be a part of it. So we're real fortunate to have that. So I will pass this on to Casey. Thank you.
My name is Casey Peoples. I'm the clinical nurse educator for labor and delivery in the OB emergency department. I'm going to start my portion with talking about personal protective equipment. In labor and delivery, our PPE requirements have evolved a lot over the past few months, but currently in labor and delivery, we wear our full PPE for all second stages of labor, pushing, and then also delivery. We do wear an N95 during our epidural procedures. Our nurses feel more comfortable with that, just with the close proximity that they do have to the patients. For our surgery patients requiring C-sections, we wear full PPE during surgery, and that is everybody involved in the surgical suite. So nurses, physicians, we do wear an N95 and gown and mask for those, and also a face shield. For our NICU staff, they wear the full PPE during C-sections for any positive or PUI patients that are in the NICU, and then also on all of the neonatal transports. The table that you see here with the PPE is used in labor and delivery outside of our rooms, just so that we have fast access to all of our PPE and we don't have to go back out to a supply room to obtain all that we need before our delivery, since we never know when we will need those. Early on in March, when we were doing planning for COVID, we realized that we did need a space for these patients to go. So our solution for that was to keep our antepartum patients on mother-baby to help this antepartum unit that we have available transform into our COVID unit. So that is what we have used for all of our PUI patients and our COVID positive patients that we have had. We have had to stock this unit and prepare it for any scenario, including an emergency department patient, antepartum, laboring patients, postpartum, because we have had patients labor, deliver, and recover on this unit. And we have also pre-opted a C-section down there. We do keep our well babies that were born to COVID or PUI moms on this unit, And we also have to prepare for a baby possibly being transported to our NICU. And then we have a designated room for our newborn follow-up clinic for our babies there. This little picture represents how we have our different zones on our unit, and that is just a visual for our nurses to know what PPE is appropriate in different areas of our unit. The red zone is where we do wear our full PPE inside of the rooms with the patient. And this also helps other hospital staff that is not working on the COVID unit to know which areas that they are safe to be in without having our COVID PPE on. I mentioned earlier that our hospital is a standalone women's hospital. Therefore, if we have any critically ill or compromised patients with COVID, we do send them to our main unit hospital that is just around the corner from our building. They do have a COVID unit that we can send them to if they need more interventions, if they become more critically ill. We have had one scenario where we have had a COVID patient that came to the women's hospital COVID unit, and she was just compromised, deciding. The OB physician determined that she did need to be sent to the main unit hospital for further treatment. So she was admitted to the main unit hospital COVID unit, where the intensivist physicians took over her care there, and our OB nurses did go over there to do fetal monitoring and anything else that she needed. She did end up with a C-section. So we had our staff go to our main unit hospital to perform that C-section. We have a very good working relationship with our staff at our main unit, and they were very helpful and just eager to help us do whatever we needed, and very willing to let us take over the OB portion of her care for sure. I'm going to turn it over to our next speaker.
Hi, I'm Kayla Reich. I'm the clinical educator for our Women's Hospital Mother-Baby Unit and our resource pool. So as you can see on this slide, if I heard this saying once, I heard it a million times. This is a fluid situation. So COVID has been ever-changing, constantly evolving. So I'm going to talk to you a little about our early days and how we have adapted some of our care as guidelines have been updated. So we actually started out not allowing anyone to wear masks. We had a few bedside staff when COVID was first being talked about in the United States that were bringing masks from home or that they had made themselves, and so we actually discouraged them from wearing those before we knew the updated guidelines and recommendations that everyone should be masking. So once we found that out, our hospital mandated for all clinical bedside staff to wear masks. So the hospital provided us with masks for us to wear in any patient interactions, but at that time we still didn't have non-clinical and office staff masking. Well, now all employees, patients, and visitors are to wear a mask at all times when they cannot be socially distanced at least 6 feet from each other. We also now wear full PPE, as Casey spoke to, in all deliveries, both vaginal and cesarean sections. And what our full PPE includes at our hospital is an N95 mask covered by a procedure mask, and we do this to prolong the use of our N95s. We then wear either a face shield or goggles. Most of our nurses prefer the face shields. The goggles tend to fog up and be much hotter and more difficult to wear for long periods of time. And then we wear a gown. We did have disposable gowns, and due to a shortage of those, we now have reusable cloth gowns that we launder ourselves. And those are also worn for the second stage of labor during pushing, just because of the high risk of aerosolization. And we had an occurrence where a patient developed a fever after delivery. The nurse that had assisted with her epidural placement had been right in her face with without an N95 on, and so just for everyone's comfort, we also decided that N95s are now going to be worn by nursing during epidural placements. So during the early days, a lot of our activities at the hospital were postponed. We canceled our annual reviews, meetings, projects were put on hold. The only thing anyone thought about was COVID. People were quarantined for up to 14 days if they were just known to be exposed to someone that was COVID positive in the very beginning. We did have some staff members that became COVID positive that had exposed other staff members. And this was prior to the masking of all staff. So now all of our areas have been measured and we have a maximum capacity allowed by the hospital. This includes our charting areas, our break rooms, our educational rooms. So we are getting back to some of our activities, but we are still limiting how many people can be in a room together. And even for our annual reviews, we made them much shorter this year, fewer people at a time, just to try and limit our proximity. So separation versus rooming in was a huge discussion when we were first talking about COVID and opening our COVID unit and having deliveries and taking care of patients. So at first, we actually were going to encourage separation of mom and baby, no matter if she was asymptomatic or only mildly sick, and we were not going to allow any visitors on the COVID unit. And we modeled that off of our main unit, COVID unit, and they still to this day do not allow visitors on their COVID unit unless it is an end-of-life situation. Once the CDC updated guidelines, and after thinking of all the negatives and positives, we decided to allow a physician and patient-based decision making. So if someone only has mild symptoms while they are laboring and postpartum, we allow them to have one support person. That support person cannot change throughout their stay, and that person does not leave the mother's room. So we provide all of their meals and everything that they need while they are here. But we have found that that offers mom better support, more help with the baby, more educational opportunities and learning, and they're a lot more confident knowing how to take care of their baby and maintain a safe distance with COVID than if they had been separated while they were here. So we've only had one mother who chose separation of her baby, and it was in the very, very early days, even before the CDC updated their guidelines. Since then, all of our babies that have been born have roomed in with their mothers. We do keep them in an isolette and try to distance 6 feet away. Anytime the baby is out of the isolette, we have mom and the caregiver mask. And so far, all of our babies we have tested at 24 and 48 hours, and none have been COVID positive. So we have had some positives come from this whole COVID situation. For instance, our physicians have section meetings monthly where they discuss patient care, order sets, changes in practice. And since we've started doing those over the phone and virtually, we've had our highest attendance ever. Our hospital normally does a baby fair every year in August, and we have vendors come and educational opportunities, and pregnant women or their families come and tour our hospital. Well, we could not do that this year, so we took our baby fair virtual, and we had a virtual baby week at the end of August, and we had physicians participate and make recordings on infant care. We did virtual tours of our units, and these are still posted on our website today for people to view. We had very high participation, and some of these videos were viewed up into the thousands of times, so many more people than could have ever come in person. We've heard from most of our patients that they enjoy having less visitors. It gives them more time to learn their baby and get to know each other. Our NICU parents are not having to share their time with anyone else or any extended family. Our nurses are enjoying this restricted visitation. Patient care is easier for them, and I have had several ask if visitation restrictions end in the future, Could we limit visitation after deliveries for a certain length of time to recover the patients? And we have definitely been expanding our communication and our learning experiences. We're learning how to record, do things virtually. During our annual reviews, we made them much shorter this year, a lot more hands-on. We just did drill after drill after drill instead of doing PowerPoints and tests, and we got some really good feedback, and staff really seemed to enjoy a lot of that, and they have seemed to enjoy a lot of the virtual communication and not having to attend so many in-person meetings and things. So there are positives to COVID, and now I'm going to turn it over to our next speaker.
Hello, my name is Charmaine Douglas. I'm the clinical nurse educator for surgery department here at our hospital. Testing. Employees are not routinely tested. All employees are required to wear a mask when in the building. Before clocking in, employees are required to check temperature, and by clocking in, employees attest that he or she is well and are without any COVID-19 symptoms. Universal screening is performed with every patient upon admission. There are specific questions asked, and their answer determines what action is taken, if any. The questions have changed from when COVID-19 first began, as more information has been gathered about the virus and how it spreads. This is also the case for visitors coming into the hospital. Their temperature is checked on arrival to the hospital, and questions are asked before they enter the facility. At this moment, some complications being COVID patients are being readmitted with pre-E symptoms. Surrounding hospitals are universally testing, whereas we are not, and this has affected our hospital when those patients are transferred to us and are asymptomatic positive cases. And then also several patients have developed symptoms after delivery, and this is why we take those precaution measures with laboring patients and C-section patients to already have the necessary equipment on just in case they come up positive after delivery. In surgery, we are currently, all patients having a laparoscopic surgery done have to be tested for COVID-19. Examples being robotic hysterectomies or any type of robotic surgeries and laparoscopic tubal ligation. During C-section, staff is required to have on full PPE, being the reusable gowns right now, hat, N95 with surgical mask over it, eye protection, and shoe covers. Due to studies showing, and the case that we have had cases that pregnant women may not show symptoms until after delivery. An N95 mask is required in all laparoscopic cases due to the high aerosolization, and it is recommended in any other surgical case when assisting with intubation and extubation. And this is all staff within the room: CRNAs, surgical techs, the physician, circulators, and even students. Patients are masked when transported to and from surgery. Once the patient is deemed stable and awake enough, she is masked in recovery before being transported out to her room. Here we have pictured, every year Pastoral Care comes around to the nursing units to bless hands. This year was different, being that they could not touch our hands, but this is an example of one way we adapted to the circumstances. COVID-19 has brought about many changes to our facility. We have all had to work together and adapt to these necessary changes for the safety of our patients and staff. It has definitely been a learning process that has required us to be flexible and willing to adapt to the changes. It hasn't been easy or without challenges, but we have pulled together as a team and have worked through these challenges and are continuing to do so. Thank you.